My name is Daniela Tatum, and today I'm going to talk to you about necrotizing fasciitis. I work at a long-term acute care facility, and out of the patients that I've had that had necrotizing fasciitis, which has been 4 of them in 7 years, they have all died. By the time the patients get to us, they've already been in the acute hospital for a month or more dealing with sepsis and being intubated and whatnot. The disease process is just pretty far advanced by the time they get to us, and we're just trying to medically manage them, giving them the benefit of the doubt that they may progress and get better. Usually by the time they get to us, they're no longer surgical candidates, so the disease is deadly. The history of my patient is Dee Dee. She's a 63-year-old female, married homemaker, brought to the emergency department by her husband because she was having shortness of breath, confusion, and a boil on her leg that just wouldn't go away. During the exam, they found the patient was verbal but very difficult to understand, only able to make out her name, so she's oriented to self only. She's following minimal commands, very lethargic. Blood pressure was 75/35, heart rate was 105, sinus tachycardia, respiration's 24, temperature was 95.8, breathing was very shallow with edema all over, large area to her left groin measuring 8 by 8 centimeters. It was hot, red, firm. Her hemoglobin was 6.9, creatinine was 3. After a Foley being placed, it was noted that her urine was very amber and concentrated, and her white blood cells were 16. Her history is she was a former smoker. She quit in 2010. She's morbidly obese, CAD, CHF, CKD stage 2, diabetes, hyperlipidemia, hypertension, and no previous surgeries. Her home medications are Norvasc, aspirin, Lipitor, Coreg, Humalog sliding scale before meals and at bedtime, Lasix. Her family history is obtained from her husband. He states that her parents deceased from old age and that her brother is alive. He's a 55-year-old smoker with renal disease and hypertension, and they have no children together. Necrotizing fasciitis is a flesh-eating bacteria, typically gram-positive group A beta hemolytic strep. It's an aggressive bacteria that invades through a miter cut or scrape. The bacteria grow, releasing harmful toxins that destroy the tissue and disrupt blood flow to the area. The first sign may be a small reddish painful area on the skin, rapidly developing into a bronze or purple colored patch. The center may become black or necrotic, and exudate is often present. Signs and symptoms is fever, tachycardia, hypertension, and confusion. Complications include gangrene, multi-organ failure, and shock. Risk factors for necrotizing fasciitis: major penetrating trauma, a minor laceration or blunt trauma, a skin breach such as an insect bite or injection of drug use, recent surgeries, immunosuppression such as diabetes or chronic renal failure or HIV infection, cirrhosis, malignancy, obesity, alcoholism. My patient has many of these risk factors, including injection drug use. It's possible that the patient gives her injections in her legs. It could have introduced the infection to her thigh. Also, she has diabetes and chronic renal failure. She is obese. Treatment for necrotizing fasciitis is I&D, stabilizing the patient, especially if they're suffering from sepsis or shock or multi-organ failure. Start them on antibiotics. So this patient in the ER, she was given a fluid bolus, started on vasopressors, and placed on a BiPAP with a warming blanket. They consulted surgery and did an I&D that day. She was started on broad-spectrum antibiotics. Over the next 12 days, the patient was able to be weaned off of the pressors and was starting to look better. Creatinine function was coming back down. She was able to converse with her family. She was learn-oriented. They decided to do a graft since the site looked so good, because they had left it open during the procedure. That way they can monitor it and do packing and whatnot. It was a very large area. The graft from her right thigh to her left thigh to cover the wound. And 5 days after the graft was placed, the patient started becoming nonverbal. Her white blood cells were going up again. She just wasn't looking very good. Her graft site did not look good at all. They cultured the wound again and to change her antibiotic regimen. She had a lot of shortness of breath, so they did a CT of her lungs. It was found that she had a PE. They started her on Lovenox. They spoke with the family, told her prognosis was very poor. The patient came to my long-term acute care facility for antibiotics and wound care. She was lethargic, arousable to sternal rub only on the BiPAP. Her vital signs were stable. The wound bed was actually red and beefy. The edges were more of a dull gray color. The wound on her leg was actually about 10 by 12 inches. It was very large. We were just doing a chlorampactin wet to dry on it. That night she was fine. In the morning she developed bradycardia, eventually going into an idioventricular rhythm, and she had some Cheyenne-Stokes breathing. It was decided that they wanted to intubate the patient, and she was transferred to the ICU. She was placed on a dobutamine drip for her heart failure, and later requiring vasopressin to keep her blood pressure up. They continued her antibiotics. Her kidneys started to fail. The family opted not to do dialysis, and eventually made her comfort care, and she passed away. Learning outcomes for this patient is, just being very supportive to the family. They've been through a lot. They want their loved one to survive this, and they have a lot of stuff going on, and they've been going through this for a very long time, and it can be very demanding and exhausting to the family and to the patient. I chose this disease and diagnosis because it is very interesting how they say the patients, have a